Welcome to the Queer Spirit Podcast. I'm your host, Nick Venegoni. Here we have conversations with artists, healers, and activists who enliven the LGBTQ communities and who empower our queer spirits to flourish. My guest today is Kerin KB Berger. KB is a physician's assistant, a PA, practicing in Los Angeles, California. She works full-time at the Los Angeles LGBT Center in the Sexual Health and Education Department. KB is also an adjunct professor at the Charles Drew University PA program, where she implemented the LGBTQI and non-binary curriculum. KB travels around the U.S. speaking to medical professionals, students, mental health clinicians, community members, and advocates. She is also the host of the Queer Meducation podcast. Today, KB shares her passions for helping bridge the gap between the medical and queer communities. She shares about her experiences educating medical professionals on queer sexual health. KB also gives us a peek into some of the important topics you can hear on her Queer Meducation podcast. You can find KB's show anywhere you listen to your favorite podcast or just online at queermeducation.com. Hi, KB. Welcome to the show.
Thank you so much for having me.
Yeah, I'm excited to have you here, another fellow podcaster.
Yes, it's funny being on the other side of things, but I appreciate the invite.
Yeah. So to start out, I thought that we would have you share a little bit more about who you are and what you do. So you are a physician assistant, and I wonder if you could share with the listeners what that is and how it's different from a doctor or a nurse.
Yeah, sure. So I'm Kerin. I use she, her pronouns. I am a physician assistant practicing in Los Angeles. I've been practicing since 2015. And basically the course of a physician assistant, and I'm very specific about the way it's pronounced. So a lot of people think physician's assistant, so apostrophe S. That is actually not appropriate. It's physician assistant. We don't belong to anybody. And we are independent practitioners or clinicians. We obtain a bachelor's degree, typically in pre-medicine classes, but could be art with pre-medicine classes. Everybody has a different background. And I would say there's a mix of the path that people take. So some people go straight into graduate school. Typically, it's a master's program. Some programs are offering PhDs now if you're more interested in research, but the majority of the programs at this point are master's degrees. And then other people will work, and that's probably the majority of the individuals. They'll go get experience, and many of the graduate programs actually require that medical experience or patient care experience. The profession itself actually started through the armed forces in the 70s. So it's a fairly new medical profession compared to nursing and medical doctors. So I think that's maybe why a lot of people haven't either heard of it, or sometimes depending on the location, there may or may not be as many PA programs, so there's not as many PAs. But that's going to be changing substantially, and maybe you've even noticed that over the past 10 years, how much it's changed, especially with the Affordable Care Act passing in 2010. So the difference between a medical doctor and a physician assistant is a medical doctor will go through medical school. Well, they'll get their bachelor's degree, and then they'll apply to a medical program, which is 4 years most commonly. And then they'll decide what to specialize in and go through residency programs, which are anywhere from 3 to sometimes 7 or 8 years of training, where it can be anything from primary care to emergency medicine to a neurosurgeon, but the residency in which you obtain is the type of medicine that you practice. Whereas a physician assistant, you go through your bachelor's degree and your master's degree, and through your training and your master's degree, I like to think of it as med school in half the amount of time. So med school is 4 years, PA school is 24 to 36 months. And you basically have a full classroom didactic year for a full 12 months. And then you go into your clinical training, typically for about 12 months to 15 months. And then sometimes you'll do a research semester, a couple extra clinicals. Some schools have, more of a 27-month type of thing. And when you graduate, you can practice medicine. So your training allows you to go right into the workforce, and depending on what you want to do, there's what many PAs like about being PAs is they don't specialize. So you can actually work in primary care for 10 years and then decide you want to go into urology or pediatrics. And there's a lot of flexibility there. And that's also, the training is quite shorter. So applying for positions when you're first a new grad, it's very important to have a good training onboarding process. And then the difference between that and a nurse. So nurses are typically bachelor's degrees. And then there's a nurse practitioner, which typically is a graduate level nurse. And I would say nurse practitioners' scope of practice are very, very similar to physician assistants. The differences are based on the certifying boards. So nurses are certified under nursing boards and PAs are certified under medical boards. And we're trained the same way medical doctors are, and nurse practitioners and nurses are trained under a nursing model. So it's a little bit different philosophy there. But ultimately, in terms of scope of practice, nurse practitioners are very similar. Depending on the state, there could be different autonomy laws and different supervision laws, but ultimately both nurse practitioners and physician assistants are independent practitioners. We evaluate individuals, we create treatment plans, we order tests, and we can prescribe medication.
And are there any limitations to being a PA that doctors don't have?
So I would say the biggest differences are when it comes to surgical specialties. So as a PA, I can never be the head surgeon, right? I'm not a surgeon, but what I can do is be the first assist to the surgeon. I can do all the preoperative and postoperative care of the patients. I can work in anesthesia, similar to a CRNA or a nurse anesthetist, under the supervision of an anesthesiologist. So I would say the main things that PAs absolutely cannot do is they can't be a surgeon, they can't be an ophthalmologist. And I think depending on the state, there's certain laws about podiatry specifically. But for example, I work private practice in a dermatology clinic, and essentially I do everything that the dermatologist does except for the very specific skin cancer surgery. So I evaluate, I can take biopsies, I can remove things, I can do the cosmetic side of things, lasers and all that jazz. So there are definitely certain things. The other thing is that PAs historically work in conjunction with physicians. That may or may not change at some point. So no matter where you're practicing in the United States or even globally, you'll always have a legal supervising physician, but that doesn't mean that they see your patients after you see them or sign off on all of your charts or approve anything. They're actually as a teammate, essentially.
Mm-hmm. Okay, great. Well, thank you for sharing all of that. It's very helpful. I've been curious myself because in the last 15 years of my life, whenever I've gone to a doctor's office, oftentimes my doctor has not been available because they're super busy and they're like, but you can see the PA. And I'm like, okay. And then I actually usually end up liking the PA more because they're less busy. And so they have more time for me. And I like it when the doctor is able to sit and listen and I can talk to them and they doesn't feel like they're rushing me out the door. And so I've really appreciated having the PA in the office to go see.
Yeah. And I think, I work mostly outpatient. So in the clinics that I work at, the PAs, the NPs, and the MDs, we all do the same thing. Nobody's scheduling the certain patients with certain people unless there's some sort of preference, or if there's a super high level case, maybe it'll be with a medical doctor, but ultimately we're all kind of there to do the same work. And also, what's I think really great about being a PA is you're trained generally, so you are responsible for knowing everything. Whereas somebody who goes through a specialty residency, if you go to your urologist and you ask them a question about your skin, they might not have a clue necessarily how to guide you and might say, please follow up with your primary care. Whereas a PA, although that might not be their direct scope at the time, they'll be able to make some recommendations and then say, if this doesn't work, you can follow up with your primary care in a month.
Mm-hmm. So I wonder if you can tell us the story of how you got interested in medicine and what inspired you to become a PA.
Sure. So I think I always was drawn to the sciences. I always kind of flourished in that science and math brain type of stuff in school, high school and middle school. And I went to a state school in New York called Binghamton University. I'm originally from New York, and majored in chemistry and minored in biological anthropology. So it's kind of on that track. However, going through undergraduate, I think I learned way more about socializing and being an independent person and kind of being more involved in service and community service and that sort of thing, to the point where I kind of needed a little space from school afterwards. So originally I thought I would go to medical school. I actually took the MCAT, studied for the MCAT. But, life happens, right? So specific life events kind of stalled that a bit. When I graduated Binghamton, I just was not ready to go to school again. So I actually moved to Austin, Texas, and worked as it was a certain type of fellowship for students at the University of Texas. And basically my job was to meet people and network and connect them with other people and other activities on campus, which was really wonderful and stimulating for me. Totally not medically related, but I met so many interesting people. It was my first time living on my own and was just always kind of drawn to that. In between graduate school and undergraduate, I moved around a bit, took classes at various schools, but also waitressed and did all sorts of jobs. And ultimately, when I kind of got a little older in my mid-20s, I was deciding whether or not I wanted to pursue medical school or PA school. And my moms are right a lot of times, really kind of pushed me towards this profession. And the more I researched it, I started taking the prerequisite courses and applied actually for 2 cycles. PA school is actually more competitive than medical school because there's less of them. And as time goes on, more people want to be PAs because it's less time, it's cheaper, and they want more autonomy. So I think when I applied, it was like 0.7% acceptance rate, and now it's even lower. So the first cycle I didn't get in, which was obviously quite disheartening, but ultimately it all worked out. In the meantime, when I really started kind of buckling down, I had to take some anatomy courses and microbiology courses in conjunction with working. So I worked in a GYN clinic for a year to gain some experience. I did an EMT basic course, and then I worked in a dermatology practice for 2 years and started PA school in 2013 in Connecticut. So I think life was kind of taking me in that direction. I think I considered going to social work school or doing something actually in the psych field, but I think my brain is a little bit mechanical in certain ways. So hence the chemistry major thing. So yeah, I really enjoyed medicine a lot once I was immersed in that clinical setting.
Mm-hmm. So I want to talk a little bit more about your podcast and some of the topics that you bring into it and bridging these worlds now. So your podcast is called Queer Meducation, which I imagine is a mashup of queer medical education. And that's actually how we connected, was I discovered your podcast. And I think it's really awesome that you are bringing these topics to the community, both communities, the queer community and the medical community, and where they may overlap and where they don't. And one of the things you talk about early on in your podcast is this idea of wanting to bridge the gap that you've seen in medical and queer communities. And I'm wondering what that gap is from your perspective.
Yeah, so I guess based on my personal experiences in school, I feel like I got a really wonderful medical education. I was prepared for my boards. My program had an excellent pass rate. People were hired, and we just had a good reputation of preparing people to go out in the workforce. However, there were many moments throughout school where I felt that things were not presented appropriately in terms of minority populations. I think there's requirements to take a psychosocial class and things like that from a credentialing perspective. And I think they did a relatively good job, but I think there was some huge gaps just in terms of when they created their curriculum versus kind of assessing it throughout. And also, I think a huge part about how queer health gets integrated into medical programs is if there's somebody either on the faculty or in the classroom that really takes ownership of that. So if you don't really have that person, it might not exist. That's kind of been my experience. So in school, I think there were like little tidbits of LGBTQ plus health, but ultimately we were not prepared to ask the right sexual health questions or talk about anal sex or anything like that. And then when I graduated, I actually worked in a dermatology clinic for a year, and just because that was my background, and I really liked the medicine very much, but I wasn't really feeling the fire there, and that was in Providence, Rhode Island. So my wife and I actually moved to Los Angeles, and I started working at the LGBT Center in Los Angeles. And I've been there for 3 years now, and ultimately, people would come in, even in Los Angeles, urban, liberal Los Angeles, and tell me stories about stigma and discrimination that they faced in medical care. And I always kind of had the sense of like, this can be something interesting, because I had never seen any sort of curriculum before. And when I first moved here, I actually interviewed for a faculty position somewhere that I currently am. I'm an adjunct at Charles Drew University in South LA. And they asked me as my interview presentation to do it on introduction to trans care and nonconforming care. And that interview presentation became an hour-and-a-half discussion. Very basic questions. Like I always say when I go into these settings, like minds are blown. And you can just see their brains just like blowing up because they have no idea, some of these people, what you're talking about.
Can I ask, what are some of the things that you're sharing with the people there that's blowing their minds? I'm just curious, like what's so shocking to them? 101
terminology, language, disparities. So one thing that's super interesting, I think, from, I guess one quote that I really love and I always keep in the back of my mind is, you don't know until you know, right? So it's not necessarily people's fault, but then sometimes it's like, where do you really draw the line,
Yeah, I imagine that there are people who are coming to these schools from all over the country, and they maybe came from an area where there isn't a lot of queer visibility and it may be conservative. And even though that person themselves might not be conservative, they just don't have exposure or experience or knowledge.
Absolutely. And the medical field in general, if you kind of look back, was very homogenous, right? So I think of like cis white 45-year-old dude, talking to me or anybody else. And that's what it's been like for a long time. Obviously that's evolved, but then that's evolved to more cis white women. Okay. And then now people are just like, what the hell is going on? This is ridiculous. So there's a little more integration and intersectionality in terms of immigration status and race and ethnicity, language, and then sexual orientation and gender identity, but we are very far from diverse.
It's the same thing in the psychotherapy community as well.
I mean, I think it's just the United States, and as we're evolving, I don't know, as a country, but it's getting more and more diverse, and people are just sick of it, right? So I think it's similar in the medical community, but unfortunately, policy change takes a very long time. So to go back to your original question, people couldn't even believe that there are statistics representing medical professionals treating somebody poorly. To me, that's very much like a privileged, ignorant situation. So it's quite interesting. I just spoke at a conference in San Diego, and it was actually a California conference. So you think in your head like, okay, cool. But I would say the majority of people at that conference were maybe like in that room were maybe 50s, majority white, presumably cis based on statistics, hetero. And like they didn't even know what I was talking about, some people. They were like, why is this a thing now?
Uh-huh.
And it wasn't intentionally like mean. It was just pure ignorance. I mean,
yeah.
So we have a long ways to go.
Yeah. So was it that experience at Charles Drew that led you to implement the curriculum there, the LGBT and non-binary curriculum?
Yeah, so I didn't end up pursuing the full-time position there because I kind of wanted to work clinically. I was fairly new. I was a brand new clinician. So what they did was I knew the director and the assistant director because they were actually alumni from my university. And they invited me back as a guest lecturer. They were like, hey, we'd love to have you come talk about LGBTQ plus intro or trans intro. And that ended up evolving into me asking them if we can implement like an actual curriculum into their weaving it into their didactic year. So typically the first semester of PA school is very basic, like anatomy, physiology, not basic, but pathology, things like that. And then you dive into medicine, your medicine courses, your physical exam courses, how to take a history. And then typically your third semester is pediatrics, OBGYN, surgery, things like that. So it kind of like flows really nicely. So what I do is I teach maybe about 8 lectures a year, and it kind of intertwines into what they're doing. So I'll teach my intro lecture while they're taking their interview course. So they learn how to take an appropriate sexual history through the lecture. Then I'll do, during their medicine course, we'll talk about preventative care for men who have sex with men, women who have sex with women, not to like box people up, but unfortunately that's kind of how medicine works. So talking more from the perspective of what we know from the data, what we don't know, and how to incorporate it into our practice. And then we'll talk more, I'll do a peds lecture, I do an aging LGBT lecture, and it's not, difficult medicine. It's not difficult compared to the academic rigor that they're experiencing, but it's still very difficult for processing perspective. So yeah, it's been really great. And the other thing I mentioned is, I work at the LGBT Center, so I live in a little bubble there. I also have a wife and all our friends, and like we live in LA and we don't think about anything except our lives. And then, right. And like, the way I look at it is like, this is my normal, right? So I was just having this discussion with my parents about normal and not normal, but, that's my normal. But then I go in and I teach and I see that I'm in reality, essentially, the majority of the US. So that is very obvious every single time I go teach, which motivates me to continue doing what I'm doing.
I'm curious to know if there are tips or suggestions you have for any of our listeners who are queer or non-binary or fall within that umbrella, who are struggling with working with their doctor or finding a doctor or a medical practitioner. Are there any tools to help people navigate that, or websites to help people find someone? Like I know here in San Francisco and in other major cities, like for psychotherapists, there are websites where people can do a search and either say they're looking for someone who's LGBT friendly or knowledgeable, or databases full of LGBT practitioners. I'm curious if there's anything like that for medical practitioners.
Yeah, so there's an organization called GLMA. It used to be known as Gay and Lesbian Medical Association, but now they just go by GLMA because it's obviously not as inclusive. And that's been around for a long time, and it's essentially a cohort of medical practitioners. So I think it was originally started by medical doctors, but it's greatly expanded. And they have a directory through their website that is self-reported. So it's not necessarily everybody, but you can sign up to be on that directory.
And that's nationwide directory?
Correct. And I know they're revamping their directory. They just got a grant through the Tegan and Sarah Foundation to make it a lot nicer template, because it's definitely a little bit dated in terms of the way it looks, but it still has great information. And it's everything from clinicians to physical therapists to psychotherapists. I mean, anybody who works in medical or mental health can report themselves on there, and it's all over the country. The other thing I would mention is, this is the day and age where the internet and telemedicine can be greatly utilized, especially for the queer community. So there are more and more startups that are focusing specifically on queer health and queer telemedicine. In terms of if you wanted to do something like a medical transition where you wanted hormone therapy, or you needed contraception for whatever reason, so there's ways to get care with actually not going physically in the office or a hospital, which can be really triggering places for queer people. So I also encourage people to even just look up telemedicine. I don't know if there's necessarily a database specifically for that. I don't think so, but I know people are doing that work out there, and it's, I think, something that is underutilized for LGBTQ people, because we just had years and years and years of oppression in medical settings. We also don't know certain things. So some people don't think they need pap smears, and some people don't think they need rectal swabs. And sexual health, if we're talking sexual health in general, is horrible in the US. And then you add this little queerness to it. I've had conversations with 19-year-olds about how things are transmitted, and I've had conversations with 62-year-olds about how things are transmitted. And so, I think finding that space, even if it's through telemed, can be really, really helpful for people, because then you don't have to go sit in that, hetero waiting room and read your stupid Cosmo or whatever the heck, look at the dumb car magazines, but even if your provider is awesome, multiple layers, steps to that process that people do not even consciously think about, but can ultimately actually have an impact on your health and mental health.
Yeah, that's really good to know that there are those options out there. And if you ever hear of any referrals, that'd be great. Because I know that there's a lot of therapists and counselors who are working online for mental health stuff, but I didn't know so much about medical stuff. I did recently meet a naturopath here in San Francisco who works online, that was the first time I heard about that. So it's good to know that there's some other doctors and PAs. Who knows? Maybe that will be your next big venture.
Yeah, I know. Seriously. Yeah. The other thing I would mention is for students or trainees or residents, every single medical or mental health specialty that I know of has some sort of group, whether it's a caucus or a organization. Through the bigger picture. For example, AAPA, which is the big PA association, has the LGBT PA caucus, which has been around forever, and the American Medical Association has GLMA, and then occupational therapists have their own. So ultimately, queer people feel very lonely in school. You're so busy, but then you're still yourself. And there's definitely resources for you as well. It might be really hard from a day-to-day basis at school, especially for trans and non-binary folks. But there is a community out there, and I encourage you to kind of guide yourself to that direction. And I'm happy to help anybody who's looking for that support.
So you've talked about some of the blind spots that the medical community has around queer issues. I'm wondering if you could share any blind spots that you see the queer community has around their physical health, especially since you sort of alluded to that a moment ago, and you've worked at the LGBT Center in LA. And so I'm sure you see a lot of people. And so I'm curious if there's any words of wisdom that you have people should be aware of around their physical health, especially trends that maybe you're currently seeing.
Yeah, so I put up this slide when I'm doing my 101 lecture, examples of how LGBTQI and non-binary people do not fit into the medical model. So there's so many examples, whether it's with fertility, whether it's if you have excess hormones in one direction. So maybe your anatomy isn't what the textbook looks like, but that's your normal way, assessing whether or not somebody has anal sex. assuming somebody's I mean, there's so many examples of how we don't fit into the general medical model, which has then progressed to us thinking we don't need medical care and mental health. And that's actually been proven through a study, you probably know about it, the minority stress model. Dr. Alon Meyer out of UCLA, Williams Institute published a study maybe like 20 years ago about how these external and internal stressors have negative impacts on our medical and mental health. And generally, we're not really conscious of it. So again, those little things that you kind of observe that you might not process actually can have negative impacts. So, I think the classic example of something that was completely ignored both medically and politically was the HIV crisis. Ronald Reagan didn't even say HIV for, I think, 8 years of his, it took him a really long time to even say it out loud publicly. And it wasn't for the community. If the community didn't get involved politically and medically, who knows what would have really happened. And then you add so now we're in 2019 where young folks never learn about HIV in school or the HIV crisis specifically. Maybe a little bit, but that was a huge part of the end of that century. And it wiped out a whole generation of individuals. But yet that history isn't incorporated into classrooms and things of that nature. So all these things contribute, create these gaps, right? So, I think sexual health is an area where education is severely lacking across the board. Honestly, I wouldn't even trust my medical provider to have all the answers because in schools, we just do not learn the intricacies. We learn the straight, hetero, sexual health, monogamy, non-monogamy thing. But people live all sorts of ways, and that's not a new thing. So I always say, don't assume anyone's monogamous, right? Don't assume because somebody's married that they're monogamous, because they might not. It doesn't matter what kind of sex they have, who they're having it with, or what their gender identity is. That's just an assumption that people make. And that can greatly impact somebody's sexual health if you don't, screen them for HIV or STIs. Another thing that comes up a lot, so we do what's called 3-point testing in our clinic. So I work in a sexual health clinic, so that's what we specialize in, right? And we do gonorrhea, chlamydia testing for not only the genital region, but also for the rectal region and the throat. And that's an opt-out situation, meaning that's standard for our clinic and you can opt out of doing it. And a lot of people say, well, I don't need to do a rectal swab. I don't know why I need to do this. But, we find things back there, even if nothing goes inside. I would say one thing that people don't realize that if there's any sort of oral sex back there, so rimming or analingus, you can get gonorrhea or chlamydia or syphilis. So, again, I go and speak about this to people who've been practicing for 20 years and minds are blown. Why would I check an anal swab on everybody? Well, you don't have to, but you should assess the risk and the need because anyone with a butthole can have anal sex. It's not a gender, a sexual orientation thing.
And newsflash, we all have buttholes.
The only people who don't have had anal cancers, and they might not.
Yeah, okay.
Some people are born without them, but it's a very small percentage, yes.
Wow.
It's a very small percentage of people. I don't like to discriminate or leave anyone out because some people have had colon cancer.
Well, thank you for queer educating me.
Right. Yeah, some people who have had certain types of cancers might have a colostomy bag, so they may not have an open hole anymore. But generally speaking, if you have a butthole, things can go in it, all sorts of things.
Even just saliva.
Right, and there's just so many things that I didn't know before I worked in the clinic, and I've learned tremendous amounts from my patients. They're the best teachers, honestly. What I love about the queer community also is that we've all kind of learned this on our own, right? Like nobody told us we needed to stick a swab back there. People advocated for that, right? Same with the throat. Around 95% of gonorrhea in the throat has no symptoms. Okay. So for example, people come in and they have a sore throat and they think they have gonorrhea. Likely not. A zillion other things can cause a sore throat. So we'll just test that person. But, long story short, you can have no symptoms for the STDs and still test positive. So that's why screening is very important as well. So, the other thing I hear a lot, and this is just through little case studies and I've read, is that some people, women who have sex with women or women who don't have sex with cis men, don't think they need pap smears. And if you have a cervix, regardless of your sexual orientation or what kind of sex you have, it needs to be screened. If you have the organs that can potentially cause cancers, and we know that they cause cancers, they need to be screened. So another example of that is our trans women who have had any sort of surgeries down there, they still have a prostate. And although the estrogen makes the prostate much smaller and changes the overall anatomy and the way the prostate functions, it's still there. It needs to be screened.
And speaking of assumptions, I think it's also important for queer people seeing their medical provider to assume, as what you're saying, that the medical provider doesn't know all of this stuff. And so it might be important for the patient to say, hey, I'd like for you to do X, Y, and Z. Because as you've said, a lot of these medical providers are not getting the education to work with our community in this way. I mean, as a therapist, I've had a lot of clients come in and they will sometimes offhandedly talk about something going on with their body. And I'm just like, well, did you tell your doctor about that? Or did they ask you about that? They're like, no. And I think that a lot of people, both with medical doctors and even with psychotherapists and counselors, they think that, well, if the professional is not asking me about it, then it must not be important. And in all cases, we don't always know every single thing to ask, even if we are well educated. Sometimes, we make an assumption or have an unconscious bias or something like that. And so it's really important for the patient to say, if they have some concern about something or even just a little curiosity, to let their medical practitioner or their mental health practitioner know so they can be aware of it.
And personally, I do not think it's the responsibility of the patient coming in to know what to ask. And that's the point that we're at as a health perspective. And again, also, I want to say this is all for outpatient general medicine. We're not talking ICU inpatient. That's a very different kind of story.
Yeah, I agree with you. I don't think it's the responsibility of the patient.
But it has to be right now. And that's part of one of the reasons that I started kind of being a little more out there with this information, because I was just so sick of seeing my friends get treated like crap, basically. And I just could not understand, going through school, the whole point of school. If everybody can write their personal statement in the most cliche way, they would say, I want to go into medicine because I want to help people. And to see the opposite happening out there is very disheartening. It's embarrassing as a fellow medical person. I'm kind of tired of it. It's 2019, people. Like, we've been around forever, and now we're starting to get more visibility, sort of more rights, and we're just tired of it. We don't want to deal with it anymore. But whether you're in Los Angeles or rural Mississippi, it still happens.
Well, starting to wind down, I wonder if you can share with us a person, practice, or experience that has supported your queer spirit to flourish.
So, I think that I'm going to use the general term of community has really impacted me. I don't think that I necessarily had the background of advocacy as a young person growing up. It wasn't something that my parents were really interested in. They were always very liberal, but I don't really think that was part of my life. And I think for me, education is a way to communicate with people. So I'm not really like a picketer or a protester necessarily. I don't really get mad or angry. For me, it's just all about slow steps. So I think all the people that came before me that did the good work, whether they were on the front lines or they were in the labs, researching HIV meds, or They were seeing people before there was a queer clinic. I think those are the people that motivate me every day to continue doing what I'm doing.
So you're queer activist medical ancestors.
Exactly, yeah. And there's a lot of them, and you have to really dig deep to read about them, but there's some really, really, really wonderful people, queer medical history for sure.
So KB, where can people find you and your podcast to continue listening to these conversations and stories about queer medical education?
Yeah, so the podcast is called Queer Meducation, as mentioned. It's on all places you can get your podcasts, iTunes, Stitcher, Google Play, all that stuff. I also have a website, www.queermeducation.com, where you can also stream the episodes there, get the show notes, find out more about the people that I interview. It's an interview-based podcast. We have topics from this morning just came out, Introduction or Basics on Chest Binding by a fantastic individual who has 8 years of experience as a licensed massage therapist in Washington, D.C. I've also interviewed people about gender affirming care. I've interviewed people who do kink. I've interviewed organizations. So it's anyone that's working towards increasing or improving the health and well-being of LGBTQI and non-binary people. I have an Instagram at Queer Meducation, Twitter, Facebook, all that good stuff. And yeah, we just came out with the 27th episode, which is crazy. But yeah, I'm also very, very accessible. If anybody has questions, comments, or feedback, I love to hear from you. So the email address is queermeducation@gmail.com.
Great. Well, thank you for being here, and thank you for the work that you do in educating both the medical and the queer communities so that we can all be healthier.
Thank you so much for doing the work that you're doing and trying to spread the knowledge and awareness out there. It's much appreciated.
Do you feel lost or stuck? Or are you alone on your healing journey? If you're seeking guidance or support, I'm here to help. I offer online coaching and counseling for queer spiritual folks from all over. Schedule your free consultation with me now by going to queerhealingjourneys.com. I look forward to supporting you on your path. To find the resources we discussed today, find the show notes at thequeerspirit.com. And if you enjoyed the show, remember to subscribe, rate, and review on iTunes. This will help us reach and support more queer people all over. Thanks for listening, and see you next time.